Dr. Sandesh Nagamani kicked us off last month with a great lead-in, and we're gathered now for our second part of this OI Teleecho series. We're really excited and delighted to have Dr. Rauch present for us today. Dr. Rauch is a professor of pediatrics and a clinician scientist at the Shriners Hospital for Children and at McGill University in Montreal, Canada. He's been at the Shriners Hospital since 2001. His both clinical practice and research program concentrate on improving the bone health in children, with a special emphasis on osteogenesis imperfecta and the role of the muscle system in bone diseases. He's also collaborating with Statistics Canada in a national population-based study that assesses muscle and bone health in Canadians. Very impressively, as we all know, Dr. Rauch has authored many publications, over 350, and has been cited almost 30,000 times. Dr. Rauch is a member of the OI Foundation's Medical Advisory Council and a co-chair of this OI Teleecho series. And without further ado, we are very excited for your talk. Thank you.
Okay, thank you, Jean. So I will share my screen for the presentation. And okay, so I'm going to talk about growth. Okay, is that the right view? Do you see
no,
it?
we're seeing the speaker view.
Okay, so that's always the problem with having two. So now it should be big. Did that change anything?
Yep, you look good.
Okay, great. So yes, so growth in children with osteogenesis imperfecta is the topic. And I will see how I can move that forward, if I can. Okay, so here's my disclosure slides. And so here is the first presentation slide. So if you have ever been to a meeting on osteogenesis imperfecta, you have probably seen this picture here a few times. And this is a nice overview from DEXA scans of total body scans in adults with OI of different types. So it demonstrates, of course, the deformities, scoliosis, but you can also see the difference in the height of these people, and it's spelled out here in the lower part of the screen. So this exemplifies that the height in adults with OI varies widely, and it's apparently dependent on the OI type. So yeah, so I'm just going to give a bit of an overview of growth studies in OI. I mean, the fact that people with OI are often short is not an exactly new observation. It was part of the first scientific case description of a 3-generation family with OI that had fractures, and they were also described as having short statures, and that was in the 18th century. Then in the classification of OI that we are using nowadays, the Sillens classification, type 1 to 4 were described. And the description of type 1 of this population included that at birth, most individuals with type 1 OI were in the normal range for the length centile. But then at the time of adulthood, about 50% were below the 3rd percentile. So showing that there is some growth deficit in OI. And it's mentioned in that paper that in OI type 3, almost all adults had severe short stature. That's part of the definition, basically, of type 3 OI. So the first growth charts for OI types was developed more than 30 years ago here in this paper that focused on the first 10 years of life. And this a study on 127 children that were from birth to 10 years of age. And this is a longitudinal study where children were measured in height once per year. So of these 127 children, they all had their diagnosis in the first 2 years of life and then were measured annually. At least many of those participants were measured annually, and overall there were 855 time points. And you can see the average for each year and each OI type in the upper part of the screen. So for type 1, type 3, type 4. The drawback or the incompleteness of this reference data lies in the fact that they are not sex-specific, so it's no difference between boys and girls was made. And also the OI was not confirmed on the genetic level as we would do nowadays. What is a bit surprising in these reference data, which makes them a bit questionable in my view, is that in type 3, the average age height remained constant until 10 years of age, and even in type 4, where really I would expect some growth, there was no height increase after age 5. So there's a bit of a discrepancy here from what I would expect in this age group. So there was a reference data or reference curves were published for OI type 1. This is now much closer to our time, 2017. This was a Polish study, and this was focusing specifically on type 1 OI. And you can see the black thick line is the growth curves for OI type 1. And the gray is the reference curves for the general population. And you can see from this that the OI reference range falls behind gradually more and more compared to the general population. So this is a study with 117 participants, also longitudinal study. Overall 823 measurements of height went into this. And again, this is a study where no genetic information was available, so the OI was not confirmed on the genetic level. And here is data from the Brittle Bone Disease Consortium. This is a cross-sectional study with 400 children and 140 adults. And this graph here just shows the average value in 5-year age categories for height set score. And this is just to document that the median height set score is decreasing with increasing age. So on top for the type 1 OI, type 4 OI, and type 3 OI. So as expected, you lose, when you have OI, you lose compared to the reference data that are here based on the CDC growth charts. So, and again, a little drawback in the study is that the OI is not based on genetic information. So we don't know who exactly in this group had a collagen mutation. So now this is a growth curve study from NIH that is based on 100 children. And the age range is 2 to 16 years of age. They also were followed longitudinally, so everyone had on average about 15 height measurements. And this data set served to generate growth curves for boys and girls for type 3 and type 4 OI. So that's limited to these two OI types. And all of these people were genetically confirmed with mutation in either COL1A1 or COL1A2. So this is basically the status of the science before the paper I'm going to present next. So we are going to talk about the growth curves that we generated from data that we had available at the Montreal Shriners Hospital, and that are based on patients who had COL1A1 and COL1A2 variants. So this came out last year in pediatric research. So that's a study where we had 573 children and adolescents with a total of 6,000 height measurements, and they all had collagen variants. And the variant, the age ranges from 3 months to 20 years. 280 type 1, 98 type 3, and 195 type 4. And you can see where the data points for this study lie in relation to the CDC 2000 reference data for height. So then we generated reference data for height and weight. So I'm showing here just one example for the type 1 OI group girls. So for each sex and OI type group, we have reference data from 3 to 36 years of age, and then another graph from 2 years to 20 years. So that's similar to how the CDC reference data are presented. We also use the same statistical method to generate these data, which is the LMS method. So these data can be used for plotting the height of patients in clinic manually when you print this out, and you can put the height of each patient. I think there's also plans to put these reference data into EPIC, so they would be electronically available. And of course, once you have these reference data, you can also use them for studies to calculate set scores. So here is a bit of a discussion of these reference data, some observations. So here, type 3 OI, the girls from 2 to 20 years of age, you see that they are reaching their final height on average here, the 50th percentile at around 13 years. And that girls with type 3 OI on average attain about 100 centimeter in height. In the boys, there is a bit of a statistical abnormality, you would think when you see this, because they keep growing until age 20. But this demonstrates a bit the difficulty of generating height or growth charts in OI, because the height data are not only influenced by growth, like we are used to seeing, but you also have surgical interventions that will affect the height. So if somebody has a spine fusion, usually they gain quite a few centimeters just from straightening out the spine. So the data that are shown in these reference ranges here are of course influenced by such procedures like spine fusion or rodding surgery and such things. The type 4 group, here in girls, you can see that they grow a bit longer than the type 3 group and reach final height at about 15 years and land here at about 137 centimeters. And in the boys, the growth in type 4 continues until 7-18, and they are at 148 on average at the end. And when you convert these raw data of each patient into a set score based on the CDC reference data, you can do a regression line that is specific for OI type and sex, and you can see that the regression lines go down, as we had seen in the previous studies that I had cited, that the growth is slower in any type of OI than in the general population. But the growth deficit is, of course, higher in type 3 than in type 1. And from what it looks like here, it's also more pronounced in females than in males, at least in type 3 and type 4. All right, so a comparison of our reference data compared to what has been published, what I have shown before, compared to the type 1 reference data from Poland, we found that the age, the height at 16, where we could compare data from the different studies, was very similar, just a 7 millimeter difference for the predicted height in an average type 1 OI boy. And also for the girls, it was very similar data here, 154 versus 155. For the type 3 group, there is a bit more discrepancy in the boys between our study and the study from NIH, but the girls are again very similar at about 100 centimeters. In type 4, again, very similar results for the boys and a bit more of a discrepancy in the girls. But of course, the groups were quite small, in sex specific and OI type specific. So there may be some, statistical variation here. All right. So then we looked at a few other things based on these reference data. We checked whether the gene that is involved in causing OI has an effect on the height within the OI types. So as you know, the collagen type 1 is produced from two different genes. One is called COL1A1, that is coding for the alpha-1 chain of collagen type 1. And the other is COL1A2, that is coding for alpha-2. And we see that there was really not much difference within the OI types based on the gene. So whether you had a mutation in COL1A1 or COL1A2 didn't really affect your height that much, either here in the girls or in the boys. And there was no systematic difference between the gene and the height curves.
Hey, Frank, it's Matt Warman. Can I ask a question?
Sure.
I put it in the chat, but
okay, I don't see that here. Sorry.
No, it's okay. So is your definition of OI type 1, even though I realize you have a mutation identified, is it a clinical definition or is it due to a haploinsufficiency mutation?
Yeah, your question will be answered on the next slide. So it's a clinical definition because, if you look like OI type 1, you have OI type 1 in our way of doing it.
Well, but I guess the reason why I asked the question then is one could imagine a mild antimorphic mutation in COL1A2 causing OI type 1 in a different way than a haploinsufficiency mutation of COL1A1. So the net effect is the same, but the mechanism is different.
Yeah, sure. The mechanism is different. But, if you cannot distinguish the phenotype between a person that has a glycine to serine variant in COL1A2 and a haploinsufficiency OI in COL1A1, then for us, this is classified as the same type because they have the same appearance. Of course, on the mechanistic level, it's a different situation.
But you did say you have mutations for everybody, right?
Yes.
So it might be interesting to look at your type 1 OI patients just with nonsense or frameshift mutations that would be haploinsufficient in COL1A1 versus COL1A2 and see if there's a height difference, forgetting about the missense mutations.
Yeah, okay. So what we have done here is similar. So here we looked at the OI type 1 specifically, and then OI type 1 based on clinical phenotype. Because we diagnose people before we even have the genetic test results. So that's one practical reason to do it like that. And also because the clinical problems that we are treating depend on the OI type more than on the gene. So here we have compared people with haploinsufficiency mutations. So basically, this is patients that have a premature stop mutation in COL1A1, and that therefore produce about half the amount of collagen type 1. And we compare that to any other mutation that results in a type 1 phenotype. So this can be COL1A1 or COL1A2 glycine substitution or whatever, C-propeptide, so any mutation that is not a haploinsufficiency. We don't have any COL1A2 haploinsufficiency because a stop mutation in COL1A2 heterozygous is not supposed to cause a phenotype. So we don't see them in our population.
Well, I guess that's my point though, right?
Yeah, I mean, they don't have OI if they have a stop mutation in COL1A2, so they wouldn't come to us. So So what we can compare is people with haploinsufficiency and other mutations. Of course, here we could compare whether it's COL1A1, COL1A2, glycine substitution, or other things. But we didn't do it here. We just compared haploinsufficiency and anything else. And yeah, so it didn't change. For the girls, it's almost superimposable, and for the boys, the haploinsufficiency group was a little bit higher in height. And my clinical impression is, apart from the height, that patients that we classified as type 1 OI, but then turn out to have a splice variant, they often have a bit more fractures, more clinical problems than the ones that turn out to have a haploinsufficiency mutation. All right, so that's this study, so this reference data study. So the next questions that I want to discuss here is, why is height reduced in OI? And I think, it's not that straightforward to answer that question. You can think of local issues. And here, even though I have seen this particular slide dozens of times in presentations, nobody has ever talked about this person here, because the legs are missing. And the text says that they were amputated. So that's one reason to have short stature, but which did not happen in our population. So nobody had an amputation. But you still could have, local issues that decrease height, like long bone deformities, as you can see here in these two individuals with type 3 OI. Scoliosis, of course, will decrease your height, as also shown here in several people. And then in children, when a fracture affects the growth plate directly, you can have growth arrest from that growth plate, and that will be a local problem that decreases your height. But then there's also the possibility that the mutation per se affects the growth plate activity systemically. And that, of course, is also an option. So they are not mutually exclusive hypothesis. But we wanted to distinguish a bit what is a local problem versus a systemic problem. And therefore, we did a study on the length of hand bones in OI with the idea that hand bones do not often have fractures and deformities. And that therefore the length deficit in hand bones should reflect the systemic growth deficit, which is like the second hypothesis here. So that led to this study here, and this is of course a very old technique. It's called a metacarpophalangeal profile, and this has been used 50, 60 years ago in studies where they didn't have techniques other than X-rays, and they took hand X-rays and measured the bone length, and therefore there's quite good reference data here for all ages. For all the 19 bones in the hand. And so we measured the length of all these bones in 144 participants of the brittle bone disease study from children 6 years and up to adulthood. Everyone had a COL1A1 or COL1A2 variant. And there were 55 type 1, 28 type 3, and 61 type 4 patients included in that study. So we found that compared to the set scores that were published from these old papers, people with type 1 OI have no significant difference. So you expect the set score to be 0 if everyone has an average bone length. So there was no statistical significant difference to 0 for most of the bones in the type 1 group. Only the distal phalanx was a bit short, as shown here. For type 4, this is this whole series, there was significantly reduced bone length in all the finger bones and hand bones. And for type 3, they were the most pronounced differences to the control. So when you look at the average set score of hand bone length, so all bones averaged out over age, in patients, you can see that there is a significant decrease with time in type 3 and type 4 OI, but this was not significant for the type 1 group. And we also compared the Z-score in bone length at the hand with the height Z-score shown here. And there was actually quite a good correlation. So suggesting that, you know, quite some part of the height deficit in OI is due to systemic growth deficit rather than local problems like deformities and scoliosis. So yeah, so that's what's mentioned down here. So the systemic growth effect clearly affects height in OI. One interesting thing, I think, from a mechanistic point of view, is that not all bones in OI grow slowly, because the skull seems to be growing at a normal rate or even a bit faster. So this is an old study from 25 years ago, where they measured standing height Z-score in OI type 1, 3, and 4, and also the head circumference. And in adults with OI, the head circumference was significantly increased for all 3 types of OI that were investigated here. So at least the skull bones grow at a normal speed or even more. Okay, so I just wanted to make some comments also on on body mass index, BMI, that is used quite a lot in recent literature about OI, and people, you know, usually conclude that type 3 OI is characterized by obesity. I just want to show why this is not a useful way of approaching things. So if you have a person here that is 60 kilograms and 160 centimeters, so pretty standard measurements, you can calculate that the BMI is 23.4, which would be the ideal situation. You would consider a normal result for BMI. So then this same person develops contractures and scoliosis, loses 30 centimeters, and let's assume everything else is remaining the same. So then the 60 kilograms are still there, but the height is only 1.3 meters. And then the BMI will be increased into a range that would be considered severely obese, but you haven't really changed your body composition at all. You just have shorter legs and scoliosis. So that's why I think BMI cannot be used in people that have leg deformities or scoliosis. So BMI is only defined if you have standard anatomy. All right. We also looked at the pubertal growth spurt in a longitudinal study. So we had 82 patients where we had annual height data from the age of 6 to 16 years, where the type of statistical approach that we used were usable. Sorry. These people all had COL1A1, COL1A2 variants. The way we did it, we fitted height data using the Priest-Baines model. So this is an established way of assessing the pubertal growth spurt with a mathematical model. And this will identify the acceleration of growth in the height curves and will produce peak height velocity, age at peak height velocity, and such things. This will only work, of course, if there's really an acceleration of growth during puberty. In many people with OI, they have a growth curve like shown in C here. So they grow constantly and then they stop growing. And then, of course, there is no growth spurt, and you cannot calculate the pubertal growth spurt. So that's what then would be considered a failed fitting of the curves. So we were able to do a successful fit in most people with type 1 OI, in about a third, in about 2/3 of people with type 4 OI, but in very few people with type 3 OI. So that's why we continued only working on the type 1 and type 4 data. You can see the height curves that were the basis for these calculations here in girls with type 1 and type 4, and the height velocity curves that were derived from this. what we found is that the age at peak height velocity was very similar in girls with type 1 OI and type 4 OI, and was similar to what had been published using the same statistical methodology in the FEL study, which is a historical study on healthy appearing American children. And the peak height velocity was actually a little bit higher numerically in the type 1 group than in this old FEL study, and was of course higher in type 1 than in type 4. So the timing of puberty, which is reflected in the peak height velocity age, is normal in type 1 and type 4 OI girls, as suggested from these data. And we have similar finding in the boys. So the age at peak height velocity was similar to the first study and was about 2 years higher than the girls that I just had shown you. And the peak height velocity was, of course, higher in type 1 than in type 4. All right. So the final question is, what is the effect of bisphosphonate treatment on growth? We had published on that more than 20 years ago, where we had done a regression analysis, a regression line height versus age specific for eye type and sex. And this is this stippled line here in yellow. And we compared the growth data of patients with the same eye type during 4 years of bisphosphonate treatment. And most of these patients crossed the line or were above it and seemed to grow faster than the regression line. And we concluded from that at the time that there was a height gain in patients with OI that had received 4 years of bisphosphonate treatment. At the time, it was pomidronate. And at 15 years of age, this corresponded to a gain of 7 centimeters in type 1, and 9 centimeters in type 3, and 12 in type 4. So now we had far more data. We used our reference data for OI to calculate OI type-specific set scores in height for 158 patients. And these patients had received bisphosphonate treatment, so pomidronate or zoledronate, for a mean duration of 8 years. And they continued the treatment until they had reached final height. So what we saw is that they increased their OI-specific height set score, both in type 1 OI and in type 3 OI, but also in the type 4. So all the groups of patients that we investigated had a significant increase, in the OI specific height set score during bisphosphonate treatment. And what we saw is that the change in the height set score at the start of treatment, at final height, depended on when you started the bisphosphonate treatment, at least in type 3 and type 4. So if you started bisphosphonate earlier, you had a bigger increase in your height set score. So that's the conclusions for the entire presentation here. So the height varies with the eye type, but within each eye type, the gene that is involved doesn't change your height that much. There is a systemic growth defect in OI regardless, that happens regardless of whether you have fractures or deformities. There is usually a detectable pubertal spurt, growth spurt in type 1 and type 4, but rarely in type 3. And the age at peak height velocity is normal in type 1 and type 4. So the pubertal timing is normal in most people with OI. And the long-term bisphosphonate treatment is associated with increased height. And I just want to thank people both on the clinical level and on the research side that have contributed to these height studies. Thank you very much.